Pain relief can feel harmless when it comes in a familiar bottle, sits on a pharmacy shelf, and promises to help you get through the day. But after age 60, some of the most common painkillers can become far more dangerous than most people realize. What makes this so serious is not just the medicine itself, it is the way your body changes with age. A pill that once seemed simple in your 40s or 50s can start affecting your kidneys, your stomach, your blood pressure, your balance, and even your risk of hospitalization in ways that are easy to miss at first. And in many cases, those problems do not start with a dramatic warning. They build quietly. I'm Dr. Marcus Evans, medical doctor and physician, and on this channel, I try to make complex health topics clear, practical, and easier to understand so you can make better decisions for your body every day. If that sounds helpful, subscribe and stay with me, because this is one of those subjects that can genuinely change the way you look at your medicine cabinet. Now, this is important to say right from the beginning. This is not about pretending pain does not matter. Pain matters. Chronic pain can wear people down physically, mentally, and emotionally. It can make walking harder, sleeping harder, and daily life more exhausting than most people around you ever realize. So, this is not a lecture telling you to simply tough it out. It is a warning that after 60, painkillers should no longer be chosen casually because the body you are treating is not the same body you had 20 years ago. That is the part many people are never clearly told. As we age, the body becomes less forgiving. Kidney function often declines gradually, even in people who feel perfectly fine. The stomach lining becomes more vulnerable. The liver may still do its job well, but it often has less room for repeated stress, especially when several medications are involved. Blood vessels become more sensitive. Balance may not be as steady. Reaction time may slow. And perhaps most importantly, many older adults are no longer taking just one drug. They may be taking medicine for blood pressure, cholesterol, sleep, blood thinning, diabetes, arthritis, reflux, heart rhythm problems, or anxiety. Once that happens, the question is no longer, does this painkiller work? The real question becomes, what else does this painkiller do inside a body already carrying other risks? And that is where things change. One of the biggest mistakes I see is people assuming that over-the-counter means low risk. It does not. Over-the-counter means accessible. It means widely available. It means you do not need a prescription to buy it, but it does not mean your body will always handle it safely. In fact, some of the drugs people trust the most are trusted precisely because they are familiar, and familiarity can create a false sense of safety. That brings me to the first one on this list. One of the painkillers I would be very cautious with after age 60 is ibuprofen, especially when it becomes a regular habit instead of an occasional choice. Many people reach for it automatically, for back pain, headaches, arthritis, flare-ups, knee pain, shoulder pain, or general soreness. It works. That is why people like it. It reduces pain and inflammation, and for many adults, it has been part of life for years. But the reason it works is also part of why it can become dangerous in older adults. Ibuprofen belongs to a group of drugs called non-steroidal anti-inflammatory drugs, or NSAIDs. These drugs reduce pain partly by interfering with the body's inflammatory signals. That can bring relief, but it also changes blood flow in places that matter, especially the kidneys and the stomach. In a younger, healthier person with good hydration and no other medications involved, the body may tolerate that fairly well. But after 60, the margin for error often gets smaller. Think of your kidneys like a highly sensitive filtration system. They are not just clearing waste. They are constantly balancing fluids, salts, blood pressure, and chemical signals that keep the body stable. Ibuprofen can reduce the blood flow those kidneys depend on to do that job properly. And when that happens in an older adult, especially someone who is dehydrated, on diuretics, taking blood pressure medicine, or already living with reduced kidney reserve, the stress can add up quickly. The scary part is that kidney strain does not always announce itself dramatically. It may begin with fatigue, swelling in the feet or ankles, a strange drop in appetite, a rise in blood pressure, or lab numbers that slowly drift in the wrong direction. Sometimes, the person has no obvious symptoms at all until the problem is already well underway. They just keep taking the same medicine because it helps the pain, not realizing the cost may be building in the background. And the kidneys are only part of the story. Ibuprofen can also irritate the stomach lining and increase the risk of bleeding. That matters much more after 60. An older stomach is often less resilient, and many people in this age group are also taking aspirin, blood thinners, steroids, or medications that already complicate the bleeding risk. Suddenly, a painkiller that seemed routine is no longer acting alone. It is acting inside a much more delicate system. This is why I want people to stop thinking only in terms of symptom relief. Relief is not the whole picture. If a pill eases your joint pain but quietly raises your blood pressure, stresses your kidneys, or increases your chance of stomach bleeding, then the true cost is much higher than it looks on the label. Now, does that mean ibuprofen must never be used under any circumstances after 60? No. Medicine is not that simple. Context matters. Dose matters. Frequency matters. Hydration matters. Other prescriptions matter. Existing kidney function matters. But what I am telling you is this. Once ibuprofen becomes a regular habit, especially without medical review, the risk can become much greater than most people expect. That is why I would never treat it casually in an older body. And yet, as concerning as that is, ibuprofen is not the one that worries me most. Because the next painkillers on this list create an even more troubling combination of false comfort, hidden damage, and risks that many people do not see until something starts going wrong. If ibuprofen was the kind of painkiller many people underestimate, the next two are the kind people often normalize. They become part of a routine. A morning tablet for stiff knees, something after yard work, something before bed for back pain, something taken several days in a row because the discomfort keeps coming back. And that pattern is exactly where the danger starts to grow. Because after 60, it is often not one dramatic dose that causes trouble. It is repetition. It is layering. It is taking something that seems manageable in the moment, while the body keeps absorbing the consequences over time. The next painkiller I would be very careful with is naproxen. A lot of people think of naproxen as simply another anti-inflammatory option, just a different version of the same idea. And in one sense, that is true. Like ibuprofen, it belongs to the NSAID family. It can reduce pain and inflammation, which is why people use it for arthritis, joint pain, muscle soreness, and persistent aches that seem to linger for days. But one reason people like naproxen is also part of what makes it risky. It tends to last longer in the body. That means people often feel they need fewer doses, and it can create the impression that it is more convenient and somehow easier on the system. But lasting longer does not necessarily mean safer. In fact, in an older adult, the longer-lasting effect can mean the body stays under that same kidney, stomach, and cardiovascular stress for a longer period of time. This matters because many people over 60 are already walking a narrow line when it comes to fluid balance and circulation. They may be taking medication to lower blood pressure. They may be on a diuretic to reduce swelling. They may have mild kidney impairment that has never caused obvious symptoms. They may have heart disease, diabetes, or a history of ulcers. When naproxen enters that picture repeatedly, it can start pushing on several weak points at once. One of the biggest concerns is the same silent kidney stress we talked about earlier. But that is not all. Naproxen can also increase fluid retention. That may not sound dramatic at first. A person may simply notice their rings feel tighter, their shoes feel snugger, or their ankles look a little swollen at the end of the day. But fluid retention can place extra strain on the cardiovascular system, and in someone already prone to high blood pressure or heart problems, that is not a small issue. And then there is the stomach. Many older adults do not realize how dangerous gastrointestinal bleeding can be, because the warning signs are not always obvious at first. Sometimes it begins as vague weakness, lightheadedness, darker stools, fatigue, or shortness of breath that gets mistaken for age or exhaustion. But underneath that, a medication that seemed to be helping with pain may be slowly irritating the stomach lining or contributing to internal bleeding risk, especially if combined with aspirin or blood thinners. That is why naproxen worries me when it becomes part of a repeated self-treatment pattern. It is not only what it does in one sitting, it is what it can do when someone takes it several days in a row, then again the next week, then again the week after that, all while assuming it is safe because they bought it themselves and it is doing what they wanted it to do. Pain goes down, risk goes up, and that trade is not always visible in the moment. But the next one on this list worries me for a different reason. Because unlike ibuprofen or naproxen, which often get attention for kidney and bleeding risk, this next painkiller is dangerous precisely because it looks gentler than it really is. It is familiar. It is everywhere. It is built into cold medicines, sleep formulas, arthritis products, prescription combinations, and many households treat it almost like a default setting. I'm talking about acetaminophen. This is the one that catches many people off guard. They hear that it is easier on the stomach than NSAIDs, and often that is true. They hear that it does not have the same anti-inflammatory kidney profile as ibuprofen or naproxen, and that can also be true in many situations. So, they place it in the safe category. But after 60, that kind of thinking can become dangerous, because acetaminophen's risk is not mainly about stomach irritation. Its danger is much more about the liver and about unintentional dose stacking. This is where false familiarity becomes a real problem. Many older adults do not take too much acetaminophen on purpose. They take a pain reliever for arthritis, then later a nighttime cold medicine, then maybe a sleep aid or a prescription pain tablet, not realizing the same ingredient may be hiding in more than one of them. The labels look different. The brand names are different. The purpose seems different. But the liver does not care what the box says on the front. It has to process the total amount that enters the body. And that is where quiet trouble begins. Think of the liver as a chemical processing center. It filters, transforms, packages, and clears all kinds of substances every day. It is remarkably resilient, but it is not invincible. Age, alcohol use, poor nutrition, underlying liver disease, low body weight, and the use of multiple medications can all reduce how much stress it can safely handle. Once acetaminophen builds beyond what the liver can comfortably process, toxic byproducts can accumulate. And the dangerous part is that early liver injury may not feel dramatic right away. A person may feel a little nauseated, a little tired, a little off, nothing that obviously screams medication damage. And because the symptoms can seem vague in the beginning, people often miss the connection. What makes acetaminophen especially tricky is that it really can be useful. In the right dose, in the right person, used correctly, it can absolutely have a role. That is what makes it so easy to misuse. The very fact that it often causes fewer stomach problems than NSAIDs leads people to assume they have wide room to work with. Sometimes they even take extra because the standard dose did not relieve the pain enough. That is a dangerous decision, especially in an older adult who may also be dealing with dehydration, illness, fasting, or other drugs. This is why I never want people to measure safety only by how comfortable a medicine feels. A painkiller can feel gentle and still be quietly harmful. It can seem ordinary and still become dangerous because of the way it is combined, repeated, or misunderstood. And once you understand that, the next part starts to make even more sense. Because the final two painkillers are the ones that concern me most when pain relief starts affecting not just organs, but alertness, balance, breathing, and the ability to stay safe from 1 hour to the next. The last two painkillers on this list worry me the most, not simply because they relieve pain, but because they can interfere with something even more basic after 60, the ability to stay stable, alert, and physically safe. At this stage, the issue is no longer just whether a pill affects the kidneys, the stomach, or the liver. It is whether it changes the way a person thinks, moves, breathes, reacts, and recovers. And once a painkiller starts affecting those systems, the consequences can become much more serious very quickly. The fourth painkiller I would be extremely cautious with after 60 is diclofenac. Now, some people may not recognize the name immediately, while others know it well from prescription use or stronger anti-inflammatory treatment plans. Diclofenac is another NSAID, but it deserves special attention because many clinicians have long viewed it as one of the anti-inflammatory options that may carry more cardiovascular concern, especially when used repeatedly or in higher-risk individuals. That matters a lot in older adults, because this is the age group most likely to already be dealing with hypertension, vascular stiffness, prior heart disease, stroke risk, or circulation problems. This is where people can get lulled into a false sense of control. A medicine like diclofenac may reduce inflammation strongly enough that the pain feels dramatically better. Knees move better. The back loosens up. A shoulder becomes usable again. The relief feels meaningful. But symptom relief is not the same thing as biological safety. And if a medication lowers pain while increasing blood pressure, worsening fluid retention, straining the kidneys, or contributing to a more hostile cardiovascular environment, then the body may be paying a price that is much higher than the person realizes. Think about it this way. Pain is visible. You feel it. You notice when it improves. But rising vascular stress is largely invisible. You do not feel your blood vessels becoming more strained in real time. You do not feel the subtle changes in clotting balance, blood pressure regulation, or kidney circulation as clearly as you feel a sore hip. That mismatch is exactly why this category is so dangerous. The benefit is obvious. The damage can stay hidden. For an older adult who already has high blood pressure, coronary artery disease, reduced kidney reserve, diabetes, or a history of swelling and fluid retention, diclofenac is not something I would ever treat like a casual solution. Even when it has a legitimate use, it deserves respect, close review, and a very clear understanding of what else is going on medically. And when people start using it repeatedly because it works better, that is where the risk can quietly climb. There is also another issue older adults often overlook. A painkiller that makes movement easier can sometimes encourage overuse of an injured or inflamed body part. The person feels better, so they do more, not realizing the medication may be masking something that still needs rest, evaluation, or a different treatment strategy. That creates a second layer of danger. The drug may not only strain the body internally, it may also make it easier to ignore what the body is trying to say. But even with all of that, diclofenac is still not the painkiller on this list that concerns me most. The one I would be most reluctant to use casually after 60 is any opioid painkiller taken outside of strict medical necessity and close supervision. This includes drugs such as tramadol, hydrocodone, oxycodone, codeine, and similar prescription pain medications. These drugs are often used because they can be very effective, especially when pain is severe. That is exactly why they must be approached with extreme caution in older adults. The danger here is not only about organ strain, it is about the brain, the gut, the lungs, and the nervous system. It is about falls. It is about confusion. It is about slowed breathing. It is about sedation that may seem mild at first, but becomes life-changing when it leads to a fractured hip, a head injury, a missed dose of another medication, or a night of dangerously shallow breathing. This is not theoretical. One of the biggest reasons opioids become so risky after 60 is that older bodies tend to be more sensitive to them. The same dose that once caused mild drowsiness may now cause significant grogginess, slower reaction time, unsteadiness, or mental clouding. Add poor sleep, dehydration, alcohol, anti-anxiety medication, sleep medication, or another sedating prescription, and suddenly the risk multiplies. And that is before we even get to constipation, which many people underestimate until it becomes severe. Opioids can slow the gut dramatically. In older adults, that can lead to intense discomfort, poor appetite, bloating, worsening weakness, confusion, and sometimes serious complications that end up needing urgent care. A person may start the medication for pain and end up with a second problem that becomes just as disruptive as the first. Then there is the issue of masking danger. A strong painkiller can make someone feel better without solving the reason the pain exists. That matters because pain is sometimes a warning sign. If severe back pain is actually related to a fracture, if abdominal pain is something more serious, if worsening joint pain reflects a deeper structural issue, then simply numbing the signal can delay the evaluation that should have happened sooner. And in older adults, delayed evaluation often comes with a higher cost. What makes opioids especially deceptive is that many people do not think of themselves as being at risk from them. They imagine the danger belongs to someone misusing medication in an obvious way. But after 60, risk does not require reckless behavior. Risk can begin with ordinary use, a prescribed tablet, a nighttime dose, a person who gets up to use the bathroom in the dark, a moment of dizziness, a missed step. That is all it takes sometimes. This is why I would never view opioids casually in this age group. Even when they are medically appropriate, they should be handled like powerful tools with very narrow margins, not like routine extensions of the medicine cabinet. The question is not simply whether they reduce pain. The question is what they may cost in alertness, stability, independence, breathing, bowel function, and recovery. And there is one more detail that matters. Many adults over 60 are taking several medications already. Once opioids enter a system that also includes sleep aids, muscle relaxers, anxiety drugs, antihistamines, or alcohol, the burden on the nervous system can become much heavier than expected. A medication may not look overwhelming on paper when judged alone, but people do not live inside paper charts. They live inside real bodies, with real fatigue, real nighttime awakenings, real blood pressure changes, and real moments of imbalance. That is why the phrase, "I only take it when I really need it," is not always as reassuring as it sounds. Sometimes the very moment a person feels they really need it is the same moment they are already tired, hurting, unsteady, underhydrated, or taking something else that compounds the risk. So, when I say these are the painkillers I would never take lightly after age 60, I mean exactly that. The danger is not just that they work. The danger is that they work in ways that can hide the price until that price becomes hard to ignore. And once you understand that, the next question becomes the one that matters most. If these painkillers deserve this much caution, how should an older adult think about pain relief in a safer, smarter, more protective way? Once you see the pattern behind these 5 painkillers, the real lesson becomes much clearer. The issue is not that pain relief is wrong. The issue is that after 60, pain relief has to be approached with much more precision. You cannot rely on habit. You cannot rely on what used to work 10 or 20 years ago. And you definitely cannot assume that a familiar medicine is automatically a safe medicine simply because it sits on a pharmacy shelf or has been in your home for years. This is where many older adults need a complete shift in mindset. The safest question is no longer, what can I take for pain? The better question is, what is the safest way to manage this pain in the body I have now? That one change in thinking can protect you from a lot of hidden trouble because it forces you to consider the full context: your kidneys, your liver, your blood pressure, your balance, your medications, your hydration, your sleep, and the cause of the pain itself. And that cause matters more than people think. Pain is not one single problem. Joint stiffness from arthritis is different from nerve pain. Muscle strain is different from pain caused by poor circulation. Persistent headaches are different from back pain that flares after activity. The more vague your approach to pain, the more likely you are to treat the symptom without understanding the source. And when that happens, medication becomes a shortcut instead of a strategy. That is why one of the smartest things an older adult can do is stop self-treating recurring pain on autopilot. If you find yourself reaching for the same medicine again and again, that is already useful information. It means the body is not dealing with a brief inconvenience. It means something persistent is happening, and persistent pain deserves a closer look, especially after 60. One of the first protective habits I recommend is simple. Know the active ingredient every single time. Not the brand name, not the color of the box, not the label you recognize from television commercials, the active ingredient, because that is where many dangerous mistakes begin. A person may think they are taking one pain reliever, when in reality they are doubling the same ingredient across several products. They may use acetaminophen for pain, then a nighttime cold remedy, then another combination tablet later in the day without realizing they are stacking the same liver burden over and over. Or they may rotate between anti-inflammatory products without realizing they are staying in the same general drug family and prolonging the same risks. If you do not know the active ingredient, you do not really know what you are taking. The second rule is to review every painkiller through the lens of your current medication list. This is especially important after 60 because painkillers do not act in isolation. A drug may look manageable on its own, but become risky once it interacts with blood thinners, blood pressure pills, diuretics, diabetes medications, sleep aids, anxiety drugs, or other sedating medicines. This is one of the biggest reasons older adults get into trouble. They think in terms of one symptom and one pill, while the body is processing 6, 8, or 10 different chemical influences at the same time. That is also why a pharmacist can be far more valuable than many people realize. Too often, people only think of the pharmacist as the person who fills the bottle. But a good pharmacist can quickly identify overlap, interaction risk, duplicate ingredients, and safety concerns that are easy to miss. If you are over 60 and taking regular medication, asking the pharmacist, "Is this pain reliever safe with everything else I take?" is not a small question. It is one of the smartest questions you can ask. Another protective step is to pay attention to early warning signs instead of waiting for a crisis. If a painkiller leaves you more swollen, more fatigued, more dizzy, more constipated, more confused, more short of breath, or suddenly raises your blood pressure, that is not something to brush off casually. The body often sends smaller signals before it sends a dramatic one. Dark stools, stomach pain, nausea, ankle swelling, reduced urination, unusual drowsiness, feeling faint when standing up, or new mental fog all deserve attention. These symptoms may not always mean the medicine is the cause, but they are exactly the kind of signals that should make you stop and reassess. Hydration matters too, more than many people realize. A painkiller that might be tolerated reasonably well in a hydrated, stable adult can become much more dangerous in someone who is dehydrated, sick, fasting, overheated, or already under strain. This is particularly important with NSAIDs because the kidneys depend on healthy blood flow and fluid balance to do their job. An older adult who takes anti-inflammatory medication during a stretch of poor hydration may be pushing the kidneys much harder than they realize. And here is another point that deserves more attention. The goal is not always to erase pain completely. Sometimes the safer goal is to reduce pain enough to function while also addressing the source in a smarter way. That may mean physical therapy, movement changes, weight-bearing adjustments, stretching, better footwear, sleep improvement, heat, ice, posture correction, or a full evaluation to understand what is actually driving the pain. Medication can still have a place, but it should be part of a broader plan, not the entire plan. That distinction matters because when medicine becomes the only strategy, people often start increasing frequency or dose the moment the pain breaks through. And that is exactly how temporary relief slowly becomes a chronic safety problem. This is especially true with stronger medications. If a drug affects alertness, balance, or breathing, then it must be evaluated not only for how well it controls pain, but for how it affects everyday survival. Can you walk safely? Can you wake up clearly? Can you get to the bathroom at night without falling? Can you think clearly enough to manage the rest of your medications? These are not side issues after 60. They are central issues. And that leads to one of the most important takeaways in this entire discussion. A painkiller is never just a painkiller in an older body. It is also a kidney decision, a stomach decision, a liver decision, a blood pressure decision, a balance decision, and sometimes even a breathing decision. The older the body, the more connected those systems become. That does not mean you should fear every medication. It means you should respect them enough to stop using them casually. So if you remember nothing else from this video, remember this. After age 60, the danger is rarely just the pain itself. The real danger is treating pain on autopilot, using familiar pills in an unfamiliar body, and assuming that what feels ordinary must also be safe. That assumption is where a lot of hidden damage begins. If this helped you think about your medications in a different way, subscribe and share it with someone who keeps pain relievers close at hand. And if you want to protect your health even further, keep going with the next video, because some of the most dangerous medication mistakes after 60 begin in places people never think to look.